I'd like to invite Dr. Vineet RATRA, sir, for his talk on macrophage-like cells on retina as early biomarker for glaucoma.
Thank you, Dr. Rohit, for inviting me for this session. So what I would be talking about is macrophage-like cells on the retina. These serve as early biomarkers for glaucoma. Well, I'd like to acknowledge the help of Mr. Satish and Deepika, our optometrists, who helped out with most of the imaging. So we do know that glaucoma is an optic neuropathy. It is characterized by retinal ganglion cell loss with retinal nerve fiber thinning, with neuroretinal rim thinning, and the only treatable risk factor is intraocular pressure. The cause of the retinal ganglion cell loss is multifactorial, and one of them is neuroinflammation. So what are macrophage-like cells or microglia? They are the first line of defense in neurodegeneration. These are the innate immune cells of the retina. They are self-renewing. They are present in all retinal layers. They are the first line of defense, and any insult leads to a microglial activation. In the early stages, it is neuroprotective. However, in later stages, it becomes neurodegenerative. There have been theories on retinal ganglion cell damage, and one of them was the overexpression of the phospholipid scramblase 1 protein when the intraocular pressure rises. This acts on the microglia, causes the release of CD68, TNF2, interleukin 1 beta, and this causes microglial activation, causing a damage to the retinal ganglion cells, which then get either phagocytized or apoptized. If you look at what Block and all have done, they have shown in studies that in patients on Alzheimer's and Parkinsonism, microglial activation and neuronal loss begin as early as 10 to 15 years before the disease manifests clinically. So does this also occur in glaucoma? So we can do a in vivo visualization of the macrophage-like cells with OCTA. And how do we do that? We take retinal images 6x6 over the fovea using a Zeiss Cirrus 6000 machine. Then we segment it 3 microns above the internal limiting membrane. These are then exported into the ImageJ or the Fiji software. These are the method is described by Ong J.K. et al., but we modified it to suit our requirements. So it's a semi-automated protocol. And once all this was done, the MLCs were highlighted with red color and superimposed on the angiographic images for better localization. So this was a pilot study we did to evaluate the macrophage-like cells in glaucoma. Our cross-sectional study compared macrophage-like cells with the structural layers. So we took eyes which were controls early and late glaucoma. The inclusion criteria was patients who were greater than 40 years of age and who had good OCTA scans with good signal strength. Those with poor scans, media opacities, retinal disorders, diabetes, other neurodegenerative disorders, surgery, or those who were on chronic treatment with neurotoxic drugs were excluded. The glaucoma was classified based on the Hodap-Parrish-Anderson criteria into early and advanced. So all patients underwent a comprehensive glaucoma workup, including an OCTA, and we compared the MLCs and structural parameters. There were 100 controls, 118 early glaucoma, and 85 advanced glaucomas. We found that the MLC counts were higher in the early glaucoma as compared to the control, and even higher in the advanced glaucoma. This is how the representative images of the normals, pointer nahi aa raha hai. Of the normals of the early glaucoma. Yeah. And this is the advanced glaucoma where the red cells tell you the MLC cells. So we compared them and we found a significant negative correlation between MLCs and ganglion cell complex, the retinal nerve fiber layer, and also the central foveal thickness. So as you can see here that this was the central foveal thickness, GCC retinal nerve fiber, and you can see that the MLC counts were less in controls, a little more in early glaucoma and higher in advanced glaucoma. There was a strong and significant correlation between the MLC and the structural parameters. So the key results were that MLC activation can be seen in early glaucoma. It shows a significant negative correlation with severity of glaucomatous damage. And this is indicating possible potential as a biomarker for neurodegeneration. However, there was a limitation. We didn't have longitudinal follow-up of these patients. Neurodegeneration severity can be predicted from early microglial alteration monitored in vivo in a mouse model of chronic glaucoma as shown by Bosco et al. There have been treatment targeted to this immune modulation. Should we consider immune modulation along with reducing intraocular pressure? If we could, we get a larger window of neuroprotection. Probably we can do an index and generate further studies. There have been use of monocyte chemoattractant protein 1 in experimental mouse glaucoma. And this is in press, this article which said where they use platelet factor 4 to attenuate the inflammation of microglia. And this protects the retinal ganglion cells in retinal excitotoxicity. They concluded that PF4 may possess neuroprotective properties through simultaneous modulation across multiple cellular pathways in glaucomatous neurodegeneration and emphasized the significance of immune-mediated mechanisms. So to conclude, it's a non-invasive strategy to visualize and monitor the MLCs. Live monitoring can give a unique insight into the pathogenesis. MLC could serve as a biomarker, and we could develop novel approaches to neuroprotect. And this may actually prevent vision loss much earlier than once that we actually glaucoma sets in. Thank you.
Thank you. Can you just play it on a few slides back? So we'll be using it for the. Can you place a few slides back? If you can play the slides again. A few slides back.
आपको पीछे करना पड़ेगा. यहाँ कंट्रोल दे दीजिए. नहीं है. अच्छा.
The slide number 25. So it's very interesting area of work in ophthalmology where many new pathways have been described, and using these pathways a lot of immune modulation can be achieved. There's a work done by, I think Tirumalesh is here. We found some neutrophils in the retinal cells which were causing degenerative changes in age-related macular degeneration, which got published in a very high-impact journal. So we are seeing neutrophils. You're looking at macrophages. I think what Dhanashree ma'am presented the other day. So that means all this is becoming a more immunomodulation, immuno-driven therapies. So a lot of your drugs today, you working on blocking an anti-VEGF or blocking some pathways, which is the downstream part. But you're not looking at what is happening, which brings it to it. So what is interesting here is that the role of say curcumin, the role of DHAs, the role of one of the very important role which we have addressed this kind of a pathway. See, macrophage and dendritic cells are there in your cornea. The dendritic cells are also antigen presenting cells, and the dendritic cells, when it touches the T lymphocytes, they have a handshake where the receptor of a dendritic cell is called the LFA, and the receptor of a T cell is the ICAM, or the other way. So what they do is when they touch each other, you release those cytokines which you mentioned. If there's a slide which you showed, IL-1 beta, TNF.
Yeah, that was before. I'll show you that.
There was one slide which is very interesting slide.
Yes. That was one of the early slides which spoke about this one. Yes.
So you have an antigen presenting cell, you have a T cells come in contact, they need to, they have a handshake and they release those factors. And those factors have an impact in many outcome, non-healing outcomes. So one thing which we should look at is trying to repurpose drugs from the anterior segment to the posterior. For example, one which can help this deactivation of that is lifitegrast or Zedra. And Zedra is used by anterior segment thing, and that blocks all those things which has been secreted. So I think a takeoff from this study would be how do you actually start looking at modulating this in the posterior segment. The exact mechanism, but only thing is there you have a dendritic cells. Of course, they're all the same antigen presenting cells. They come under the same category. So how do you block it is through this. So you should probably take this work forward in trying to see how we can use that. And it's an ICAMP modulator which Tirumlesh is going to speak. I mean, just an insight into from what I learned from your presentation.
I think so. If we were to be
Yes. I just wanted to make a comment. So this is really very exciting study that Vineet has shown that there is an MLC activation and probably there is an immune basis for glaucoma, and there is a possibility that we can use early neuroprotection, and especially in situations like a normotensive glaucoma or patients with high risk characteristics, you can start neuroprotection much earlier and try to prevent the vision loss. However, the crux here is that the neuroprotection and the inactivation of these microglia is actually a very delicate balance. So what I understand from whatever literature I have searched, so when you are giving these immunomodulating drugs, there is a very fine balance between these MLC deactivation. So if you give it in small quantity, it is a protective, and the MLCs can get deactivated, and it will save the it will prevent neurodegeneration. But beyond a certain limit, it can be a detrimental, and you will have in fact more neurodegeneration. So the problem is not in repurposing the drugs or identifying, but it is to identify this thin line between the neuroprotection and neurodegeneration.
Absolutely. So what I would suggest is that if you create the same experimental model where you have created that dendritic with the amount with that, and you use repurposing drugs on them to see if it can actually block, then it will be a good translation.
Yeah, so what was shown was that if you give it in smaller quantities, it is neuroprotective. But if you give it in higher quantities, it becomes.
These are all very low quantities. Yes. You can even use
giving
the
anterior will be.
Yeah, exactly.
Yeah, I think that makes good sense.
Thank you.
Thank you.
Dr. RATRA, I had the anterior segment in the trabecular meshwork also you have macrophages, which when activated, initially, as you said, mild macrophage activation actually clears the trabecular meshwork, but severe it actually blocks the trabecular meshwork. So I think the conditions like dry eye also activates the. You have any thing to say? Is the dry eye actually exacerbates POAG?
So thank you.
So I was just curious from the clinical point of view. This is regarding those who have a family history of glaucoma. We always keep telling them they need to go for RD screening and things like that. So do you think, would you see a different pattern, or will it help in identifying those with a family history, whether they're going to eventually get clinical glaucoma or at risk? Thank you.